The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us in person or virtually at annual.apic.org.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection.
Welcome back to the APIC 5-Second Rule. I'm your host, Silvia Quevedo, and this is a special episode. It's the APIC 50th anniversary episode. We're coming to you in June. It's annual conference, and there's quite a buzz about the APIC annual conference for a lot of reasons, but not the least of which is we are celebrating 50 years. And to help us celebrate on this episode is our current APIC President, Linda Dickey. Linda, remember, has done a couple of episodes with us. She did the construction episode, but today she's going to talk with one of our former presidents, Barbara Russell. And so welcome, Linda.
Thank you, Sylvia. It's great to be here.
I want to remind everybody who you are. Obviously, you're the 2022 APIC president, and thank you for that. But you're also the senior director of epidemiology and infection prevention at UCI Health, University of California, Irvine, correct?
Correct.
Okay, I wanted to get that right. And I know you've done so much for APIC over the years, among many things, serving on committees. You also represented us and worked closely with the American Society for Healthcare Engineering. You've worked with ASHRAE, the American Society of Heating, Refrigeration. Oh, let me get that right. The American Society of Heating, Refrigerating, and Air Conditioning Engineers.
Right.
Yeah, it's hard to say.
Yes.
I know you have tons of experience, and I'm just thrilled that you're here to help the organization mark this important year.
Well, I'm thrilled to be a part of that, and I'm very thrilled to be on this 5-Second Rule with Barbara. She is one of my mentors. She helped me get started in my career, so that's extra special for me to be here with her today.
Hi, Barbara.
Hi, Sylvia. Hi, Linda.
Hi, Barbara.
Barbara, I'm thrilled to sort of meet you as well. I know that you are currently the infection preventionist with the state of Florida Public Health Department HAI team, but you were president back in 1994, and
That's right.
According to the information I was given, you joined APIC back in 1976. My understanding, or what some of the APIC folks have shared, is you've been to almost every annual conference since then. Is that true?
Absolutely.
Oh my God.
Actually, it was 73. I might have missed a renewal and got re-upped at 76, but I've been a member since 73.
Okay. So since like day one.
Just about.
Well, that's wonderful. That's wonderful. And this is thrilling because it's year 50. So,
right.
I mean, we're over 30 episodes at the 5-Second Rule. There's no shortage of content. That's the good news. But this episode is really, I think, or what I want to do is to highlight some of what the organization has achieved in 50 years, but also to give an overview of Like, what was it like back then? So I'm going to start with you, Barbara, because you go way back. Talk to us a little bit about your history and how you came to join APIC.
Well, at the time, I was working as a nurse manager in a community hospital, and we had the isolation unit on our floor. I'll backtrack by telling you when I was a student nurse at Jackson Memorial Hospital and had 3 months in isolation, I said, once I get out of here, I'm never going to have anything to do with infectious diseases. And look at me now. So when my colleague, Lonnie Kicklighter, who was one of the first people that met in North Carolina to try to get APIC started, said, you want to get into infection control. So I decided to do that, and I went back to Jackson Memorial Hospital, and I spent a year or so there. And then I went back to Baptist, where I stayed as infection prevention for 40 years until I retired in 2019. And as I mentioned a few moments ago to some of you, I failed retirement and came on board when the pandemic came along, when the Florida people called me and said, well, I helped out for a couple months, and here I am.
Wow.
But again, it was, we really needed each other. We had to identify with everybody in our community who was doing infection control. A group had already started meeting informally, which ended up becoming eventually APIC Chapter 8 for Miami, now known as Miami-Dade. But you need to find people. As Linda mentioned, I had mentors, and I'm glad to hear that I was able to mentee her some, but we had to group together, and we had to help each other out. We didn't have the resources like we do now. We created some of the original resources, but we didn't have them to start with.
Wow. As current APIC president, you've been involved with a lot of activities to mark this important milestone for the organization. Talk to us a little bit, or what you know of the history of APIC in terms of back in the 70s and a small group coming together. What was happening at the time that really spurred the creation of this organization?
So we have had one of the big privileges of being president this year has been being a part of some of the interviews that we've done with founding members of APIC. And one of those was Kay Wenzel, another Pat Lynch that we did interviews with. And both Kay and Pat, and I'm sure Barbara can talk to this as well, spoke to the issue of staph infections that were going on at the time that they entered the field of infection prevention specifically. Not that there weren't other types of infections going on, but Pat had commented about the ward structure of patient care units, where there would be anywhere from 8 to upwards of 16 or more patients all side by side in beds next to one another. Hand hygiene sink at the end of each room. It really unheard of to have a lot of single patient rooms at the time, at least from what she described. Mm-hmm. And so there was a real need to figure out how these infections were being transmitted and try to, obviously prevent them. And it was very interesting to hear how the data was received. She said there was a lot of culturing of the environment, of thinking that maybe family members might be the source. But she said in just observing, you could see that the proximity of the patients and the inability to clean hands as frequently as it might be necessary really might lend itself to cross-transmission. So those were just a couple of the things that it really struck me as structural issues that probably lent themselves to infections emerging and the need for this profession at that time. Barbara, does any of that resonate for you?
Yes, it certainly did. I remember when I was still being a nurse manager, and the current infection control nurse, the first one the hospital ever had, came out of the operating room. And that in the old days, that seemed to be a lot where the IP people came from. But I asked her one day, what is it you do? And it was very unstructured. But one of the things they were doing at that point was doing a lot of environmental culturing. And I said, well, then what do you do with it? Well, she wasn't really sure. There was, as I said a few minutes ago, there wasn't really a good direction or policies, protocols to go by. So we were just kind of forging forward and realizing, like Linda said, the distance between beds, the availability of hand hygiene, and eventually decided that the culturing wasn't at that point in time relevant. And so it kind of lost favor, so to say. Of course, now in the last several years, what do we talk about? The importance of keeping the environment properly cleaned and making sure people are doing it properly and they know their contact times and all. So it's made like a 360 turn from the beginning till now in the 50th anniversary year.
Okay. Well, that's really interesting because, well, first of all, I actually worked in a ward like that much later than the 1970s. Enough said about that, but I can completely appreciate the challenges just by virtue of the structure. But Barbara, can you share a little bit with our listeners who may not be as familiar with what we mean by culturing?
Well, of course, most of us understand about culturing people, but when you culture the environment, you're taking swabs of doorknobs, of bed rails. Maybe in some cases, if you think something's associated with water, you would culture the water. Just things in the environment.
Got it.
Some things like we call high-touch areas today.
Okay. So there was this emphasis on the environment, less on, where you were putting patients or maybe hand hygiene, which as you were both talking, I'm thinking to myself, wow. I mean, was even back in the 70s, would you say there was and here I'm going to use culture in the term of how we operate as professionals and as humans. Would you say, Barbara, the culture within healthcare facilities was, well, it's inevitable that people are going to end up with infections. That's just the way it is.
To a degree, yes. And that might vary from one facility to the next. But some facilities were concerned about, we need the money from an infection. And so weren't as eager. That didn't last too long, thank goodness, because we started getting education. We started educating our administrators and everyone else the importance of it. And we don't want people to get infected. And that's been a big change through the years. The administration has come a long way in being very supportive in most facilities of infection prevention and control. And finally, in the last few years, recognizing the importance of it just isn't one per hospital. When I retired, there was 4 of us in my department. And shortly after that, it rose to 10.
Wow.
So they recognized the importance and also about making sure that folks get educated, That was another thing that has happened is that sometimes because of all that's happened in the ensuing years is that some of my colleagues lost support for attending conferences or for taking the CIC exam and paying it out of their pocket because of their dedication and wanting to do it. But I see some of that changing now as well, which is a good movement forward, that they understand that they need a qualified, trained person to help them prevent these infections.
Yeah, no, for sure. We talk about that a lot here on the 5-second rule. Linda, I want to direct the next question to you. And Barbara started this with the notion of, she was a nurse. We know that many infection preventionists came to this work from nursing. You yourself have a background in nursing, correct? So can you share a little bit of what you know about why that is? Obviously, dedicated professionals coming together to say, you know what, I think we need to really look at these infections and how we can stop them. And can you give us sort of a brief history of the profession and how it gelled?
I think it was a kind of a natural evolution that nurses would sort of have been at the start of being infection preventionists because we were in healthcare and we would have had an understanding of at least the infectious process. But I think it's clear as we've sort of evolved as a unique profession that there are other disciplines who had an interest and a propensity for becoming infection preventionists, microbiologists, public health professionals, various disciplines that have come forward. And as we've sort of refined what we are as an entity, what the core competencies are, I think we are at a point now, 50 years later, where we are realizing, and part of the work that we're doing at National APIC is actually defining an infection preventionist as a unique, something that is going to be defined by the Department of Labor as its own job code and its own thing, and that has evolved. One time a physician became a physician, but people came into that through different disciplines, and a nurse became a nurse, and so now we have an entity called an infection preventionist, but it took a long time for it to evolve and become its own defined, specialized area of knowledge. There was a woman, I'm sure Barbara can speak to her as well, better than I can, but her name was Claire Coppage, and she was at the CDC, and she was in charge of a course that taught a lot of the early infection preventionists, and she was a real driver for pulling together APIC. And so I think have a lot of respect for her desire to, see that there was an organization where the professionals that were interested in this, and not just nurses, but it was intended to be a multidisciplinary organization of people that wanted to see infections controlled. And that vision that she and the other early founders had for staying connected, supporting each other, developing processes that they could share, developing a structure for sharing data, what that data would look like. All of that had to be built. And people like Barbara contributed to that.
Yeah. Well, speaking of Claire Coppage, the other one from CDC was Julie Garner. And the first book that many of us had to go by was called The Brown Julie, because Julie Garner wrote it. And if you put anything in the time capsule, if anybody has a copy of it, it's to go in the time capsule.
Wait, I want to make sure I heard that correctly. The book was called Brown Julie?
Yes.
Wow.
After her. It was brown. It was the cover was brown.
The Brown Julie, I love it.
It sounds like a recipe, actually. That's why I had to ask.
The first thing that came out from CDC that I'm aware of. That was some guidance for us. It preceded the infection control isolation books that came later and all, but it was
wow.
It was very helpful.
We've
if you went to the course
find the Brown Julie.
Yeah.
It sounds either like a cocktail or like a recipe for something. That's why I had to.
There should be a cocktail named it.
Yeah.
Maybe at annual, someone will come up with a recipe for the Brown Julie. I love it. I did not know that. That's fascinating.
But talk about where we've come from. We've come from that now to this, to all kinds of resource material, the APIC text, all the other resources we have. To today's person coming in, they're so fortunate to have all those resources available to them.
Sure. Barbara, talk to us a little bit about the working conditions in those early days. I mean, we mentioned the ward, and the one sink at the end of the hall, but talk to us about, the day to day. What were the working conditions like? What was known then about transmission? What was the PPE like? How did you get buy-in from other healthcare workers in those early days?
Well, obviously we tried to start with the hand hygiene, which we're still trying today, 50 years later, to get better compliance with it. In fact, my mother, God love her, I lost her a few years back. But one day she asked me, she says, "What is it you do now?" And I said, "Well, Mom, I'm trying to get people to do hand hygiene properly." And she said, "Wait a minute, you have all those letters after your name and you're telling me that's what you turned out to do?" And I said, "Yeah, Mom." And she said, "I taught you that when you was a little girl." And I'll say, "Yeah, but you know what? Some people must have been mad at their mother the day she taught them because they don't do it." So it's a constant battle. It was a battle then. It's still a battle now. It's gotten better now that we have more resources like hand sanitizer. We didn't have the alcohol hand sanitizers in each room or outside the room back then. You pretty much depended on soap and water, and it wasn't always clearly located. Like was said before, one was at the end of the hall, so it was hard to. But that was the big thing we promoted. Is making sure your hands were properly cleaned. And then we started working on patient placement. If you had to have 4 people in a room, did anybody have a Foley catheter? Try not to put them in with the ones that didn't. Try to put people in the room that were, what you might say, compatible as far as having any devices or any portals of entry or whatever that would be more easier to cross over to than somebody that didn't have a live IV line in. Because in that day and age, also, a lot of people went in the hospital. The mother tells the doctor, "Oh, I'm so exhausted. These kids are driving me crazy. Oh, I'll put you in the hospital for a couple of days and let you rest up." So there wasn't a lot of deep care that was needed. A lot of them, and of course nowadays, that doesn't happen. So,
well, that's an interesting point, Barbara. Let me back up a little bit on that. Yeah, there was the exhaustion, nervous breakdown. Remember that non-defined term that our psychiatric and psychological colleagues are probably cringing with that term. But let me go back, because back in those days, length of stay was longer, correct? Or am I just making that up?
No, it was longer.
Okay. For even acutely ill.
And the pay structure, as Barbara alluded to earlier, you got paid fee for service. So you got paid for every day that somebody stayed in the hospital. You got paid for every Band-Aid. It was very different than, those pay structures now where we're tied to quality outcomes. And so it is completely shifted the thinking, the financial thinking.
Yeah. So Barbara, I know I interrupted you, but let me ask you about what was it like, hand hygiene aside, working with the physicians, with the other healthcare workers, trying to get buy-in about, hey, we've got to start paying attention to these infections, and they shouldn't be happening. Can you share a little bit about that?
Well, speaking for my own area of Miami, we were very fortunate that we had some key infectious disease doctors who added a lot to it. Dr. George Counts was my first boss at Jackson, and Dr. Joel Ehrenkrantz. Between them and a couple other ID doctors, we actually formed a consortium that was operational for several years, aside from our activities with our APIC chapter, growing APIC chapter. And they would help because they would come to the hospital and make rounds with us, and we'd have them talk to the doctors, doctor to doctor there were some doctors that understood, and the doctors have changed a lot too. I mean, back then, you didn't, everybody was scared to death to remind the physician he didn't wash his hands, because he would go down to administration and report you, and, next thing you know, you got your hand slapped or whatever. But that has changed also through the years. But early on, it was helpful to be able to hook up with some ID doctors, either in your own facility or in the community, to help you work through some of those. And having a strong committee chairman. My experience was I was very fortunate. Even though he was a pathologist, he was very involved and very supportive of us and what we were trying to accomplish in those early days.
Wow. What about, personal protective equipment in terms of access? Was there an understanding of the importance of gowns and gloves and eye protection at that time?
Probably more so the gowns and gloves than eye protection per se. Because again, even though we were seeing infections, they weren't to the degree they are today to an extent. But we did have carts. We had carts we could put outside the room. We had, in the beginning, we all had different kinds of signs. That was something else that came along with time, was the standardization pretty much with the help of CDC and others of standardizing the signs to use and the fact that the equipment had to be right outside the room. But, we didn't really have that many on isolation as we do nowadays.
And Barbara, I mean, we've talked on different episodes with our APIC infection preventionist members about a big part of the role of the infection preventionist is to conduct surveillance. How much of that was going on, and who was doing that back in the 70s in those early days?
Well,
or was it happening at all?
Well, yes. In the early days, as I got into it, we had, for example, as I said, I started infection prevention at the Jackson Memorial Hospital. And there was, it's even a bigger complex now, but it was big back then. And there was 4 of us, and we had assigned areas. At the one point, I was over maternal child care and pediatrics. So we would go make our rounds every day to see if anybody had any questions, to see if anybody was on isolation, were they doing it properly, if they did have an infection, to document it. But we didn't have, and we tried to collect data and do diagrams and everything to present to the committees. But along came NHSN, and all that has really been beneficial, as much as people sometimes groan and moan about having to report everything to NHSN. It really has become a better way to organize it and get feedback from.
And just to clarify, that's the National Healthcare Safety Network.
Right. Sorry about that.
Yeah, no, that's okay. I think our regular listeners are becoming quite savvy with these, but just in case. So a lot of paper and pencil where now we have electronics. That, I know there are still challenges. Linda, in those early days, there were a handful. We're upwards of what now, 15,000 members?
Right. Amazing, right? I think that original meeting that Barbara alluded to, the original meeting to put together the first charter, I think there were 23 people from across the country that Claire Coppage had engaged from those that had taken the original CDC course. And so if there's anybody that doubts that, an individual or a small group cannot make a big difference, APIC's a clear example of that.
Wow, from 23 to 15,000. And, Linda, talk to us a little bit about what, in your experience as an infection preventionist and your connection with APIC, talk to us a little bit about, the reporting and the shifting culture around what is acceptable and not acceptable. I mean, APIC has said, 0 infections. I know we're moving away from that, but talk to us a little bit about that shift and where we are now with that.
Well, I started in infection prevention the year Barbara was president, so 1994. And at that time, the payment models were evolving. So one of the early things that I remember is that I was in Orlando at that time in a large community system. And although we were collecting data and submitting it to, at that time it was called NNIS, the National Nosocomial Infection System, which has evolved to NHSN, there was still this thought that a lot of infections were not preventable, that you were going to get an infection if you came in. Now we have so much data on how to prevent infections, and that a good percentage of them are preventable. So between, I think, that shift in seeing the evidence and realizing the preventability, and also the shift in the payment structures that reward good outcomes and processes that support preventing infections and other, bad outcomes, DVT, blood clots, falls out of bed, pressure ulcers, all of that is tied to hospital reimbursement. And so that has shifted the thinking to, we need to prevent these things to make people safer when they come in the hospital, to support their healing, and to try to get them out of the hospital as quickly as possible. And that's been a big transition just in the short time that I've seen from 1994 to 2022 as I've been an infection preventionist.
Yeah, I'm sitting here thinking to myself throughout, just from when we got started, that this hasn't, it's 50 years and that's a chunk of time, but it seems like such a short time, and that I can't believe even in the 70s this was going on, I guess, is my personal reaction to it.
Right. And the Institute of Medicine reports that came out on To Err is Human, and and then the follow-up report to that one, they pointed out that things are happening within healthcare that we need to look at our processes to make healthcare safer. And it wasn't about people wanting to do harm or intending to do harm. A lot of it was, processes that we needed to either study or follow and make it easy for people to do the right thing. So like Barbara said earlier, there wasn't hand gel, available for everybody every time you turn around, but technology vendors came to the table and then there were people like Elaine Larson and others who studied the efficacy of that and published it so that we could then put it out there for people to believe in it. And then, all of those types of baby steps, if you will, have helped us evolve to where we are today. And hand hygiene is still, the one thing that we probably slip on when our attention span is short or whatever, but it's gotten a lot better, I think, over time. It's and there are other things like that. I'd be really interested to hear Barbara's thoughts around the era when HIV was emerging and the difference in the use of gloves, because while they were available before, my impression is that, even that evolved during that time.
Absolutely. Yes. In fact, just to backtrack for a moment, to tell you that when I decided to go into infection control, some of my nurse colleagues at the time said, "You're crazy. Why are you going to do that? There's no future in that. We have vaccines. We have antibiotics." And I just laughed at them, and I laugh at them now and say, "Look at this. Every year since I've been in infection prevention and control, there's either been a new disease, a reintroduction of a disease, or, of course, the whole involvement of multiple drug-resistant organisms, et cetera." And that started becoming true with HIV. I mean, HIV, the day I got that first MMWR and talked about these cases, I thought, there's something going on here. Mm-hmm. And it really put, infection control had to learn about it real quick because people didn't want to touch anybody. They didn't want to go in a room. They wanted to keep the door shut. That's when they did start wearing gloves. As much as we used to try to get back to your question about using PPE, I used to have a one-on-one with some people because they would empty bedpans or change colostomies or something and not wear gloves. And they say, "Oh no, we can't do that." So people think that we think they're dirty. And I said, no, they wouldn't. You're just trying to protect you from taking it to someplace else. Now we can't get them to take the gloves off.
Which is interesting that anyone would not want to,
I know.
Anyway.
Well, they were even taught that. I mean, I had nurses tell me that they were taught that in school, that you didn't put gloves on unless the doctor ordered it because the patient would think that you think that you're dirty. Fortunately, that way of thinking changed.
Right. Well, and that's interesting because you're right. I think in most, well, I shouldn't say most, those of us of a certain age, if we think about pandemics, or epidemics, the HIV crisis looms large, certainly in recent years, H1N1 and Ebola, depending on where you live. Mm-hmm. But I do want to ask Barbara, where what I hear you say suggests that there was a fundamental lack of understanding of disease transmission. Is that too strong a statement? I mean, when you're trying...
Yes, especially something like that, because when it first came out, they didn't know a whole lot themselves. And it's sort of like when COVID started. Everybody keeps saying, well, every time you turn around, they're changing. Well, because they're learning more about it. They have to come out with what they think best to begin with. And then as they learn more, then they change the guidelines or whatever. And it was the same thing with HIV. And of course, then when we first found out about a couple of nurses who acquired it through a needle stick injury, that really, I will tell you that HIV really thrust me into several years of heavy duty involvement on behalf of APIC as well as the ANA. I chair the ANA HIV task force and was one of the writers of most of their policy procedures, which ended up going back down to our colleagues in the hospitals to help them out. But it really did. It's one of the first things I think that started bringing us up more to the top, recognizing the role we played and how important it was for us to educate and make sure people had the equipment they needed to protect themselves as well as the other patients.
Wow. Yeah. I mean, I think so much has happened and so much has been done. So what about the products? I mean, Linda, you started to talk about the technology, right? I feel, again, just as an observer, I feel that there's so much out there. I mean, back in the early days, Barbara, did you still, tons of companies making products, and how did you sort through that? Were you involved with the purchasing? What did you have available beyond soap and water?
Personally, I was. Not everybody, not all hospitals supported their infection control people being involved in product selection. And of course, that's changed a lot now too. But I was very involved in what we would use and was very respectful for the companies that came forth with stuff. Mm-hmm. And of course, nowadays, really thank them for all their support of APIC, all they do for us, all the companies do for us. But now with the way purchasing is done, infection control, I believe, in a lot of places don't have as much opportunity to input as they used to, because they go through and they can purchase X number from this company and save, thousands of dollars. We don't, it's not that they don't care that you don't like it. They just think it's okay. But hopefully some people still are able to participate in product evaluation in their facilities. It's very important to have the thoughts of an infection prevention when you select something, whether it's a safety device, whether it's a cleaning, not a device, but a cleaning equipment or a fluid, the actual disinfectants themselves. It's very important. So I always encourage her, just push. You just say you need to talk to them. You need to see this product before we put it into use. And, maybe stop something that is not as good as another.
Linda, what have you seen? I mean, what are your thoughts on some of the technology and product access since 1994?
Well, we've seen a lot of interesting things come to market and some really, innovative things, which have been lovely. Like just as an example of a certain segment, some of the sharp safety devices and some of the technologies to try to keep healthcare workers a little safer have been fantastic. I agree with Barbara that I think it's a bit variable across, at least in the United States, how engaged some infection preventionists are in that process. We are fortunate at my facility that we are fairly embedded in both the procedural areas that are obviously very intensive in products and services, in the OR, but then outside of that, the bedside and ambulatory. But sometimes substitutions are made, like Barbara says, sometimes cost should be a big factor because we're always trying to figure out how to be able to take our money and use it most effectively. But you do have to be very careful about making sure that you want the best product possible for patients. So we do want to see infection preventionists at the table for that.
Yeah, great point. And I know at annual conference right now is a lot of great industry partners and strategic partners that, from their side are really trying to come up with the innovative solutions and work with our members. And so, yeah, shout out to that group.
Absolutely.
What do you guys want to see for the next 50 years? Barbara, I'll start with you.
Well, I know I won't be here, but I wish I could be here to see what's going to happen. But I think we'll see more technologies, that will help us with some of our duties, like the hand hygiene. I mean, there's some of the technologies out there now will be improved on. For example, when you have to go in a room and badge to show that you washed your hands, some of them are good, but some of them need some improvement on it. And I'm sure the companies will come through with some of that. I just hope that we continue to grow as we have over the 50 years. We've come from the Brown Julie to the APIC text and more. We've come from when those first few years when we had APIC conferences, I think it was the third or fourth one we had here in Florida, and the chapter put it on. We didn't have much. Because it wasn't there. It wasn't that they wouldn't help us. It just wasn't there. But we wanted to have a national meeting here, and our chapter got together. And Dottie Thomas did the program. I did the industry people, and this and that. And we had a very successful conference. And that has grown such over the years, even including the number of vendors we do have and the number of people that do attend. And I see that continuing to grow and grow. And hopefully, as Linda mentioned earlier, we get that recognition as a kind of an independent kind of profession that she was talking about. And I think that the world of nurses, microbiologists, and public health is a beautiful marriage. In fact, when you have more than one person in a department, I always encourage them. If the microbiologist is the first person, get yourself an RN. If the first person is an RN, get yourself a microbiologist, because the two blend perfectly. What you don't know about micro, they know, and you learn from them, and they learn from you as far as the direct care practices that you might not have had experience with having not gone to nursing school. And public
Good
health,
point.
more and more coming out of public health. And in fact, my team I work with, several of them all they have is an MPH, but they're picking up on the infection controls. We go into these long-term care facilities and deal with COVID, and they're just doing a tremendous job.
Mm-hmm. Linda, what about you? What do you see for the next 50 years?
Well, I think that we are going to grow stronger as our own entity. As she mentioned Dottie, and I was just thinking about Dottie Thomas, who's just a treasure. But as Barbara mentioned, I think that we are going to continue to evolve as a profession. I think we'll have more sophisticated tools, such as artificial intelligence, to help us, if we embed that in together with our electronic medical record, to be able to watch patient movement, as well as have a better idea of caregivers, so that we can, together with whole genome sequencing, have a better idea about what's going on with outbreaks, because we're still basically working like a caveman, trying to figure out how bugs are moving around and who's associated with what and where it's come from. But I do think we've got some really amazing technologies on the horizon. Having said that, we're still taking those very first baby steps in some sectors like long-term care, where we're still struggling even to get expertise in there and get appropriate policies. And it's not that I don't think it's not recognized now, particularly with COVID, but it took 50 years to build the acute care side to where it is today, and we have got to come alongside long-term care and make those environments safer, both for patients and for workers. I also see, like, precision medicine, genetic engineering. We're going to see a whole new world of what vaccines look like, again, like we did with COVID. And I think the way medicine is done is going to look very, very different. The way people are treated for infectious diseases, and what pathogens cause, like some of the cancers. We're going to see treatments evolve in an amazing, different way for our future. So it will be very interesting.
Yeah, I think it's a bright future for the profession, certainly. Anybody listening, we did a whole episode on how to become an IP. I think there's a lot of exciting new opportunities on the horizon, looking for more diverse members of the community, certainly looking to address those areas that we haven't looked at around health equity. And like you said, there's a lot going on in technology. So it's exciting, but it's also great to be here, just marking the moment, marking the year that we turned 50. Barbara, thank you as a pioneer for APIC, a pioneer for infection prevention. We thank you so much. And Linda, your leadership this past year has been amazing, and we thank you for your time. And enjoy the conference, everyone. It's exciting to be back together after a 2-year hiatus. And with that, just remember, everyone, to check out all the amazing resources at www.apic.org.
Thanks for listening to the 5-Second Rule, produced by the Association for Professionals in Infection Control and Epidemiology staff and the APIC Communications Committee, in partnership with Human Factor. Audio tech is Blake Alphen.